Woolfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Today, we're talking about prolonged pregnancy. We've spoken previously about trying to keep babies in as long as possible to prevent the complications of prematurity. But how long is too long?
The current definition of prolonged pregnancy is a pregnancy that extends beyond 42 weeks or 294 days from the last menstrual period. Prolonged pregnancy is also known as postdates or post-term. Now, we usually consider term to be 37 weeks onwards, but did you know that term pregnancy can actually be broken up into 4 categories? Early term is from 37 to 38 plus 6 weeks. Full term is from 39 to 40 plus 6 weeks. Late term, 41 to 41 plus 6. And post-term is 42 weeks and above.
Right, so why do we need to have so many categories of term pregnancy? I thought we used to consider anything beyond 37 weeks as term.
So this is correct. We did used to consider term to be anywhere from 37 to 42 weeks gestation. It was thought that the outcomes of all babies born in this interval were good and pretty much the same regardless of when the baby was born. Increasingly, though, research has shown that this is not the case and that neonatal outcomes can vary depending on the timing of delivery at term. Because of this, a work group was convened in 2012, which recommended that term be divided into different categories to more accurately describe deliveries occurring beyond 37 weeks gestation. This is how we've ended up with the 4 different categories of term pregnancy: early term, full term, late term, and post-term.
Oh, okay. What are the differences between the different groups then?
Babies born at early term appear to have poorer neonatal outcomes than those born at full term. You might remember from our caesarean episode that increased respiratory distress in early term is one of the main reasons we delay elective caesarean section until 39 weeks gestation. But there is also some suggestion that NICU admission rates, neurodevelopmental outcomes, and birth weight may also be affected. The rates of adverse neonatal outcomes seem to be the lowest among uncomplicated pregnancies delivered at full term, which is between 39 and 40 plus 6. For this reason, you'll notice that a lot of improvement projects have focused on reducing non-medically indicated deliveries before 39 weeks gestation.
Yeah, we've definitely been looking at that at our hospital actually, especially with the Every Week Counts campaign. You really have to justify why you're ending a pregnancy before 39 weeks, whether it's a caesarean section or an induction. But anyway, let's get into our topic of the week, prolonged pregnancy. So what's the data for post-term pregnancies?
In general, post-term pregnancies are associated with worse neonatal and maternal outcomes than full-term pregnancies. The main reason we worry about post-term pregnancy is because of the increased risk of stillbirth, but there is actually a whole list of fetal and maternal complications that can occur if the pregnancy goes too long. The majority of complications are due to either excessive fetal growth or placental insufficiency. For the baby, the risks of prolonged pregnancy include fetal macrosomia and shoulder dystocia, meconium aspiration, low APGARs, neonatal acidemia, neonatal encephalopathy, and cerebral palsy. There's also an increased risk of infant death in the first year of life, and also something called post-maturity syndrome. For the mother, prolonged pregnancy increases the risk of induction, operative delivery and caesarean section, 3rd and 4th degree perineal tears, postpartum hemorrhage, prolonged labour, labour dystocia, intrauterine infection, and not to mention anxiety and frustration.
So the risk of stillbirth is often mentioned as a reason for induction. Can we talk about this for a little bit? Like, how big is the actual risk of stillbirth for a post-term pregnancy?
Compared to delivery at term, the risk of perinatal mortality is doubled at 42 weeks, quadrupled at 43 weeks, and 5 to 7 times higher at 44 weeks. Despite this, the absolute rate of perinatal death is low. So if we want to talk actual numbers, at 40 to 41 weeks, the risk of stillbirth is 0.8 to 1 in 1,000. This then increases to 1.2 in 1,000 at 41 to 42 weeks. At 42 to 43 weeks, it's 1.3 to 1.9 in 1,000. And at 43 weeks, the risk is 1.3 to 6.3 in 1,000. Now, this is quite old data, and it comes from large population studies from the UK. If you want to know what's happening a little closer to home, let's check out some Australian stats. So according to the 2022 preliminary Australian Institute of Health and Welfare report, the perinatal death rate at 37 to 41 weeks was 1.4 in 1,000, and 7.2 in 1,000 at over 42 weeks.
Okay, so in Australia, about 0.6% of pregnancies will go over 42 weeks gestation. If we apply that to 2022, where there are about 260,000 births in Australia, that means that around 1,500 babies were born after 42 weeks gestation. And of those, about 11 babies died. If those babies had been delivered before 42 weeks with a perinatal mortality rate of 1.4 in 1,000, then we would have only expected 2 babies to die. So in Australia, an extra 9 babies per year died because of prolonged pregnancy. Do we know why post-term pregnancies have higher perinatal mortality rates?
The increased rates of perinatal deaths are thought to be due to intrauterine infection, placental insufficiency due to placental aging, cord compression leading to fetal hypoxia, asphyxia, and meconium aspiration. I've also seen a few studies into the reasons behind perinatal death for post-term pregnancies, and the majority appears to be inadequate reporting of decreased fetal movements and inadequate interpretation or management of abnormal CTGs.
Yeah, it's so important that women are counselled on the importance of monitoring fetal movements and to present if there's any reduction in the strength or amount of movements, especially once we're getting towards post-term. Now, Mel, you also mentioned post-maturity syndrome. Can we explore that a little bit further? What is it?
Post-maturity syndrome is also called fetal dysmaturity syndrome and is basically a term used to describe fetuses with characteristics of chronic intrauterine malnutrition. Not all post-term babies continue to grow along a normal growth trajectory, and this is primarily because the aging placenta starts to fail, leading to placental insufficiency. This results in the birth of a small gestational infant who usually appears malnourished. Post-maturity syndrome occurs in about 10 to 20% of post-term newborns, and the neonates have a characteristic appearance. Babies are long, thin, and growth-restricted with subcutaneous wasting. Their skin is stained with meconium and is dry and parchment-like with peeling. The skin appears loose over the thigh and buttocks and has prominent creasing. Lanugo hair is sparse or absent, while scalp hair is increased. In utero, these babies are at increased risk of cord compression due to oligohydramnios and fetal distress due to placental insufficiency or cord compression. As neonates, they are at increased risk of morbidities associated with growth restriction, like hypoglycemia, polycythemia, perinatal asphyxia, meconium aspiration, and persistent pulmonary hypertension. They are also at risk of neurodevelopmental complications, like seizures and cerebral palsy.
Okay, quick summary time. Term pregnancy can be divided into 4 categories. Early term, 37 to 38 and 6. Full term, 39 to 40 and 6. Late term, 41 to 41 plus 6. And post-term, which is greater than 42 weeks. In Australia, about 0.6% of babies are born post-term. Complications of post-term pregnancy are mainly due to macrosomia and placental insufficiency. Neonatal complications of prolonged pregnancy include fetal macrosomia and shoulder dystocia, meconium aspiration, low APGARs, neonatal acidemia, neonatal encephalopathy and cerebral palsy, increased risk of infant death in the first year of life, post-maturity syndrome, and death. Maternal complications of prolonged pregnancy include an increased risk of induction, operative delivery, and caesarean section. 3rd and 4th degrees tears, PPH, prolonged labour, labour dystocia, intrauterine infection, anxiety, and frustration. The rates of perinatal mortality are increased with post-term pregnancy from 1.4 in 1,000 at term to 7.2 in 1,000 after 42 weeks. Post-maturity syndrome is a constellation of findings, including growth restriction, subcutaneous wasting, meconium liquor, oligohydramnios, absent vernix, lanugo hair, and peeling skin, and it's associated with increased morbidity and mortality.
I guess another thing that's really important to talk about here is how we determine gestational age in the first place. Calculating an accurate estimated due date has significant implications in a pregnancy, and if you get it wrong, it can actually lead to problems. Overestimation of gestational age can lead to a higher rate of diagnosis of post-term pregnancy, and thus a higher rate of unnecessary induction. On the flip side, underestimating gestational age may expose a pregnancy to increased risks of post-maturity that may have been prevented with timely delivery. We also have gestational age cutoffs for certain interventions, like steroid administration, magnesium sulfate administration, and even neonatal resuscitation. So it's really important that we try and get the due date right from the very beginning. So how do we correctly date a pregnancy?
Traditionally, pregnancies are dated by determining the first day of the last menstrual period. We would then use Nagel's rule to calculate the due date. By convention, the estimated due date is 280 days after the first day of the last menstrual period. Nagel's rule is to add 7 days to the first day of the last menstrual period and then count back 3 months. Now, it's important to know that dating by the menstrual period assumes a few things. We firstly assume that the woman has a regular menstrual cycle of 28 days. Then we assume that the woman is regularly ovulating on the 14th day of the cycle and that she also conceived on that day. We also rely on the woman's recall. I don't know if you remember the first day of your last period, but if you're not planning a pregnancy and not checking your periods, it's actually really hard to remember. In fact, 40% of women are likely to not correctly know the first day of their last period.
All right, Mel. Now, I just know you have something to say about Nagel.
Of course I do. So, Franz Karl Nagel, or Nagel, I'm not sure which, was a German obstetrician and professor of obstetrics in 1812. During then, he published a textbook which outlines a rule for calculating the estimated date of confinement. Add 7 days and subtract 3 months from the first day of your last period, and boom, baby's due date. For the past 200 years, this has been known as Nagel's rule. Now, this rule actually wasn't created by Nagel at all. Rather, it was developed by a Dutch physician called Herman Boerhaave, who actually came up with the calculation in the first place. Boerhaave is thought to have published it in 1744, and Nagel may have simply been quoting that method in his 1812 textbook. Either way, Nagel's rule is what we have been using for years to calculate estimated date of confinement based on the menstrual period. Nagel also coined the less commonly known terms Nagel obliquity, which is also known as anterior asynclitism, and the Nagel's pelvis, which is a variety of obliquely contracted bony pelvis where there has been arrested development of one of the sacral alae.
Oh my God, I want to get something named after me. Maybe I should get the Pecoraro pelvis. I'll keep trying. Now, these calculations obviously assume that the length of a pregnancy is equivalent to 10 menstrual cycles or 40 weeks. How do we know that that's how long a pregnancy is supposed to last?
Okay, so the average duration of pregnancy from implantation of a fertilized ovum to birth is about 266 days. However, pregnancy is typically dated from the first day of the last menstrual period, meaning that the duration of pregnancy is actually to be considered 280 days. This means that technically, we consider you to be pregnant for 2 weeks before you've even conceived. Now, there have actually been quite a few population-based studies that have confirmed that the average duration of pregnancy is about 280 days, meaning that 50% of women will birth their baby before 280 days and 50% will birth their baby after 280 days. The vast majority of women will birth within 10 days of their estimated due date. Now, there is some variation in human gestational length, and certain factors can influence the length of a pregnancy. White women, tall women, nulliparous and overweight women have all been shown to have longer pregnancies. Because of the ethnic variation in gestational length, there have even been suggestions to consider a shorter gestational length of 39 weeks in Black and South Asian women and to commence intervention for post-maturity at 40 to 41 weeks instead of at 41 to 42 weeks.
Wow, that's so interesting. Imagine if we could individualize gestational length and accurately predict when a baby would be born. Like, surely that's in our future. Anyway, we digress. Let's get back to calculating due date. And you mentioned that the first way to calculate due date is by applying Nagel's rule to the last menstrual period. What's the second way?
Apart from the menstrual period, the second and most accurate way to confirm gestation is through the use of ultrasound. We tend to use ultrasound in the first trimester up to 13 weeks and 6 days, and this is known to be the most accurate way to establish or confirm gestational age. Now, ultrasound measurement in the first trimester is based on measuring the crown rump length, and it has an accuracy of about 5 to 7 days. Once the baby measures bigger, more than 84 millimeters, which corresponds to a gestation of about 14 weeks, the accuracy of the CRL to estimate the due date decreases. So if you're less than 9 weeks, and the difference between the LMP-based due date and the ultrasound-based due date is more than 5 days, then you should use the ultrasound-based due date. And if you're between 9 and 13 and 6 weeks gestation, and the discrepancy between the LMP and ultrasound-based due date is more than 7 days, then you should use the ultrasound-based due date. Beyond 14 weeks, it gets a bit tricky. We tend to rely on biparietal diameter, head circumference, abdo circumference, and femur length for dating, and the variation can be anywhere between 10 to 21 days. We'll pop a little chart on Instagram to help you remember the calculations if your earliest scan is beyond 14 weeks. A pregnancy without an ultrasound estimation that confirms or revises the estimated due date before 22 weeks of gestation should be considered suboptimally dated.
Okay, and what about if the patient had IVF? Do we calculate due dates the same way?
If the pregnancy resulted from assisted reproductive technology, the ART-derived gestational age should be used to guide the estimated due date. This is based on the age of the embryo and the date of transfer and will usually be given to the patient by the IVF specialist, and you should not change the date regardless of ultrasounds. Typically, an IVF due date is calculated by adding 266 days to the date of conception and then subtracting the age of the embryo. For example, if you had a 5-day embryo, then you would add 261 days to the date of conception. If you had a 3-day embryo, then you would add 263 days to the date of conception.
Okay, so for dating the pregnancy, calculate the last menstrual period based due date using Nagel's rule, which is add 7 days and subtract 3 months from the first day of the last period. Compare the last menstrual period based due date with the first trimester ultrasound due date. If it's under 9 weeks, the difference is 5 days or less, you can use the last menstrual period based due date. But if the difference is more than 5 days, you should use the ultrasound due date. If you're between 9 and 13 plus 6 weeks and the difference is less than 7 days, you can use the last menstrual period based due date, but if the difference is more than 7 days, you should use the ultrasound due date. And IVF pregnancy due dates are accurate regardless of what the ultrasound says. So do we know why some pregnancies are going too long? Like, what are the reasons?
Well, unfortunately, we don't really know. The most common cause for prolonged pregnancy is actually inaccurate dating. This is why it's so important to get that due date right at the first visit. Using ultrasound to help calculate the due date instead of the last menstrual period alone has actually been shown to reduce the chances of induction for postpartum pregnancy by 50%. Aside from incorrect dating, there does seem to be a genetic predisposition. Maternal and fetal genetics can influence the initiation of labour. In rare cases, certain fetal disorders can also lead to an increased risk of postpartum pregnancy. Conditions like X-linked ichthyosis are associated with placental sulfatase deficiency, which leads to extremely low levels of estriol and other hormonal changes, which can delay the onset of labour. In general, the duration of these pregnancies tends to be about a week longer than pregnancies without the disorder. Anencephaly can also lead to prolonged pregnancy, with an average gestational length of 311 days or 44.5 weeks. Factors that interfere with myometrial contractility can also contribute.
And that brings us nicely into our risk factors. What are the risk factors that make someone more likely to have a prolonged pregnancy?
The maternal factors that increase the risk of prolonged pregnancy include nulliparity, maternal age over 40, and obesity. A history of prolonged pregnancy and a family history of prolonged pregnancy also increase the risk. So if you've had one previous prolonged pregnancy, you've got about a 15% chance of having another prolonged pregnancy. Fetal factors that increase the risk include placental sulfatase deficiency in conditions like X-linked ichthyosis, fetal adrenal insufficiency, fetal adrenal hypoplasia, anencephaly, and male babies.
What is it about male babies? They've got a higher chance of prolonged pregnancy, but also if you have a preemie male baby, the survival outcomes are much poorer. Maybe boys just need more time to cook? Okay, so we've covered incidence, risk factors, and complications of post-term pregnancy. What can we actually do about it?
So for pregnancies that reach 41 weeks gestation, our options are induction or expectant management with additional fetal monitoring. Both of these options are associated with low absolute rates of adverse outcome, and patients should be counselled on both approaches and the maternal and fetal benefits and risks of each. Our general recommendation is for induction of labour after 41 weeks gestation, because studies have shown that induction at this gestation reduces perinatal mortality and morbidity without increasing the caesarean section rate. A 2020 meta-analysis of randomized controlled trials comparing labour induction with expectant management showed that induction at 41 weeks was associated with a 70% reduction in perinatal mortality and stillbirth, a 10% reduction in caesarean sections, a 28% reduction in macrosomia, a 25% reduction in meconium aspiration syndrome, and a trend towards a 12% reduction in NICU admission. An IPD meta-analysis of randomized trials specifically compared induction at 41 to 41 plus 2 weeks with expectant management until 42 to 42 plus 1 weeks in uncomplicated pregnancies, and found that induction reduced neonatal mortality and severe neonatal morbidity from 1% to 0.4% without increasing cesarean rates.
So what gestation should we actually be doing a post-dates induction? I've seen 41 weeks, 40 plus 10, 41 and 4, 42 weeks. What does the evidence say?
So the evidence is a little unclear, and guidelines tend to vary between 41 and 42 weeks. There was actually a trial done in Sweden in 2019, the SWEPIS trial, Swedish post-term induction trial. This trial compared induction of labour at 41 weeks versus expectant management and induction of labour at 42 weeks. This was a multi-centre, open-label, randomised superiority trial that recruited 2,760 women with a low-risk, uncomplicated singleton pregnancy. The primary outcome was a composite of perinatal mortality and morbidity. The trial was actually stopped early due to a significantly higher rate of perinatal mortality in the expectant management groups. 6 deaths occurred in the expectant management group compared to no deaths in the induction of labour group. This study concluded that induction of labour should be offered to women at no later than 41 weeks and could be one of the few interventions that reduces the rate of stillbirth. The recently updated Cochrane Systematic Review of Randomized Control Trials on Induction of Labour by Middleton et al. Included 20 studies investigating outcome at 41 weeks. Compared with expectant management until 42 weeks, induction of labour at 41 weeks significantly reduced perinatal mortality, neonatal intensive care admissions, and severe neonatal morbidity, while the absolute rates of all these adverse outcomes were small.
I actually remember when the SWEPIS trial came out, our hospital almost immediately changed the policy for post-date inductions to be done at 41 weeks rather than 41 plus 3, which was the norm previously. Since then, I've moved on to other hospitals, and the policies seem to vary from 41 weeks to 41 plus 3. What are most hospitals recommending at the moment?
Queensland Clinical Guidelines recommends induction for women who've reached 41 weeks gestation. However, states that the exact timing depends on the specific risk of stillbirth, patient preferences, and local circumstances, with most hospitals offering induction of labour at 41 plus 3. South Australia Health and the King Eddie's Hospital in Western Australia offer induction of labour from 41 to 41 plus 3, and Monash Hospital recommends induction from 41 weeks and close to 42 weeks. At the moment, we don't really know the optimal time for induction in week 41, so I couldn't tell you whether induction at 41 plus 3 is safer than 41 plus 4 or 41 plus 5, for example.
And what if a woman declines an induction? What's her alternative?
Expectant management is the alternative to induction, and given the absolute low rates of complications, is not an unreasonable choice. It's really individual preference here, and the woman's choice should be respected. After all, the number needed to treat is 400 inductions to prevent one perinatal death. That said, if given the choice, most women will actually choose to have a post-dates induction. If a woman chooses expectant management, fetal monitoring should commence from 41 weeks gestation and includes twice per week CTG and ultrasound assessment of amniotic fluid volume. In South Asian women, it has been suggested that fetal surveillance should actually commence from 39 weeks gestation, since the risk of stillbirth at 39 weeks in a South Asian woman is similar to the risk of stillbirth at 41 weeks for a Caucasian woman, that being around 1 in 1,000. This is actually also in the Monash guidelines. What we're looking for here are any CTG abnormalities or any evidence of fetal compromise, such as oligohydramnios, which would be a trigger for delivery. Amniotic fluid can actually become severely reduced quite quickly, typically within about 1 or 2 days, and so twice per week monitoring is really important. Monitoring the Dopplers is actually of no proven benefit in postpartum pregnancies. Now, it's important to know that there's no evidence for the timing and frequency of fetal monitoring, and actually no clear evidence that increasing fetal monitoring reduces perinatal mortality. CTG and ultrasound only determine well-being at that point in time and cannot guarantee well-being outside the time of the test. Stillbirth is unpredictable and might still occur even if you have a normal CTG and ultrasound. Still, increased fetal surveillance for postpartum pregnancies is recommended worldwide for postpartum pregnancies undergoing expectant management instead of induction.
Thanks, Mel. So let's wrap up this episode with a summary of the important points on prolonged pregnancy. Prolonged pregnancy is defined as pregnancy duration beyond 42 weeks or 294 days from the last normal menstrual period. In Australia, 0.6% of pregnancies deliver post-term. The risk factors include primiparity, maternal age over 40, obesity, and previous prolonged pregnancy, having a male fetus, a fetus with fetal adrenal insufficiency, fetal adrenal hyperplasia or anencephaly, or placental sulfatase deficiency. The cause is unknown, but it may be due to inaccurate dating, genetic predisposition, such as with X-linked ichthyosis, or factors that interfere with myometrial contractility. Fetal complications of prolonged pregnancy include stillbirth, post-maturity syndrome, meconium aspiration, macrosomia, shoulder dystocia, neonatal acidemia, low APGARs, neonatal encephalopathy, cerebral palsy, and infant death within 1 year of life. Maternal complications include an induction, operative delivery, and an increased risk of caesarean section, 3rd and 4th degree tears, PPH, prolonged labour or labour dystocia, anxiety and frustration, and intrauterine infection. Although stillbirth risk is increased, the overall rates are still low, about 1.4 in 1,000 at term and 7.2 in 1,000 from 42 weeks. Strategies for prevention of prolonged pregnancy include early routine dating ultrasound to prevent overdiagnosis of prolonged pregnancy, membrane sweeping at term, and an induction for postdates. Induction is recommended because it reduces the risk of stillbirth, Caesars, macrosomia, meconium aspiration syndrome, and NICU admissions. The number needed to treat is 400 inductions to prevent 1 stillbirth. If a woman declines an induction, increased fetal monitoring is recommended with twice-weekly CTGs and ultrasound AFI from 41 weeks gestation in Caucasians and from 39 weeks gestation in South Asian.
And just before we wrap up the episode, I'd just like to give a quick shout out to my third-year medical students from Griffith at the Sunny Coast. You know who you are. You better be listening.
So that wraps up this week's episode on prolonged pregnancy. We hope you learned something. If you have any comments or feedback, please email us at theutirinesound@gmail.com. Keep an eye out on our Instagram at theutirinesound for our Instagram summary slides later on in the week.